Thank you very much, Dr. Shobha Nair, for giving me this opportunity. You won't believe when I first got an invitation, when I saw it from Bombay Psychiatric Society, I thought this is the most prestigious invitation I have ever got. And from such a dynamic society, and of course, I should acknowledge that you have been very kindly looking after each and every aspect of my travel and journey. And I didn't expect you to read my CV in such detail. It's just one of those things, you ask and I give, and nobody reads actually. So you are the first one who has read. So thank you very much. I'm really very, very delighted. You might, of course, you might not know, I have my roots in Maharashtra. And I did my schooling in Ambernath, in district Thane, near Ulhasnagar. And I should say my 1/10 of my life was spent in Maharashtra. So I'm talking about, 60s. And that was a time when I was in a school and the central schools were introduced. Kendriya Vidyalaya was introduced at that time, maybe 64 or 65. And the first central school was in Ambernath where I studied. So that was also the time when Marathi was made compulsory in schools, and so 1 year I studied that, and so I still remember some of the poetries. Thui thui nach maja anganat mora. So, Gudyano Patingodu Chala. So there are a few things I remember, and it is there in my roots. So Ambernath was a very good place, and Kalyan was the main station there. So whenever I hear about Thane, and so I really feel very, nostalgic about it. So it's very good. Now, I'll just. How will it go down? Next. Okay. No problem. Yeah, you might be wondering, why a psychiatrist. I trained in PGI Chandigarh and is doing work in cancer and psycho-oncology. And when I finished my MD, I'm a very strange person in terms of psychiatric training, okay? We had 2 years MD at that time in PGI, and so I did from 79 to 81, and we didn't have to do a thesis. So, he was mentioning Dr. Vig. So, the students went to Dr. Vig and said, what is the use of thesis? We don't learn anything, it's a waste of time. He said, okay, for a few years we will do MD psychiatry without thesis. So we never did a thesis. So, and then it's very strange because rest of my life I have been a guide for MD thesis. And many times I went to the ministry and I said, I think 2 years psychiatry is enough. Why should it be for 3 years? And, it can be like me. So if you want, anything more than that, it's a different matter. But anyway, in ministry, nobody listens. So they didn't listen. So then when I finished my MD psychiatry, I was jobless. There was no senior residency left for me. And so I was offered a research officer post for ICMR pain project. And that's how my journey started. So I started with a pain project after doing MD. And it was to look at pain in many specialties in PGI, out of which radiation oncology was one of the main departments, medical oncology. And so palliative care was not there those days. So we started looking at pain in nephrology, cardiology, medicine, OBG, and a lot of it was oncology, and of course psychiatry, which was non-organic pain. And from there I started looking at the psychosocial aspects of cancer and psychiatric disorders and all that. And then came a Commonwealth Fellowship opportunity, which was not for psychiatry, it was for oncology. And they had 4 seats. This is 1987 or 86, when they wanted to select 4 people. So when I went, it was held in Shastri Bhavan in the Ministry of Education. and they looked at, they had 4 seats, so they took one medical oncologist, one surgical oncologist, one radiation oncologist. I was the only psychiatrist who went. He said, what will a psychiatrist do in oncology? I said, I've been doing a little work. It was very brave of them to award that to me, and I worked in Christie Hospital in Manchester, which is a cancer hospital, for a couple of years, just doing cancer work at that time, and of course doing communication skills and other things there. Well, now coming to the main topic, the common psychiatric disorders in cancer. So let's for the time being forget ICD-11 or DSM, though we can keep it at the back of mind. But when it comes to you and the patient or a caregiver or oncologist, they have to understand what you are talking about. So the commonest disorders are related to distress, adjustment disorders, affective disorders, mainly depression, then anxiety disorders, many fears and phobias, anticipatory nausea and vomiting, somatoform disorders, something which I would like to talk about after some time, sleep disorders, post-traumatic stress disorder, body image problems, and sexual dysfunction or disorders of intimacy, alcohol and substance use, but in specifically pseudo-addiction is what we would like to talk about in oncology. And then of course delirium, organic mental disorders, and psychosis, which is less common. So to begin with, let's talk about distress. Distress is the easiest thing to assess, and like we assess pain, in a visual analog or a numerical analog from 0 to 10 or 0 to 100, distress can also be measured in those terms. So for many of you who might not be aware, pain is the 5th vital sign, which has been recognized by the WHO, which means that for every person we must ask pain. And psychological distress is the 6th vital sign, which has been recommended by the International Psycho-Oncology Society. And most places would, all cancer patients should get a 6th vital sign assessed. So it's multifactorial. It can be because of a number of factors. It's on a continuum from a normal distress to severe distress. There is some logic behind introducing distress, because like Dr. Shobha was mentioning in the beginning, when people talk about depression in cancer, then people think, oh, already I have one stigmatizing disorder, now I have another stigmatizing disorder, which is a psychiatric disorder. So it's even more distressful. So we thought of talking about distress. Now distress is more generic. It's not depression. It is, we all know what distress is. You might find it difficult to describe. But even in the country, we have common terms which can describe distress. Sankat, kasht. So, and I don't know, you might be having a more appropriate word in Marathi. So it is very easy to ask about, you have a disease, how much, distress do you have? And then we can deal with it. So it can occur during any stages of the disorder. It can start even before the diagnosis is made, when a symptom or a lump or a ulcer or a wound or something which is detected. And I had one patient recently. I'm doing seva in a general hospital, but I look after mental health and psychiatry there. And one lady came with a lot of distress, and because 1.5 years back she had some symptom on the head, and when a very enthusiastic doctor, whosoever it was, told that it can be anything, it might be cancer. So I don't know what made him say that, but he was just being very open, and then all investigations were normal, but this fear did not go out of her mind. And 1.5 years, this lady has been suffering with a whole lot of psychiatric symptoms. So it can start even before a diagnosis is made, and then, in the rest of the course of disease till end of life. It can relate to a number of things. It can relate to pain, fear, sadness, social concern, spiritual concerns. Maybe in the second talk, I'll talk a bit more about spirituality and existential concerns. And this is what is called as a distress thermometer, which I said, either you can show the picture, and when a person says, what it is, then they can mark whether it is the family problems or physical problems or spiritual problems, and how much of it is contributing to it. And they can have, they might have history of psychiatric disorders, depression, cognitive impairment, communication barriers. A number of factors are there which contribute to distress, and some which cause increased risk for distress. And like I said, periods of increased vulnerability start from finding a suspicious symptom, then during an assessment or working out, finding a diagnosis. Waiting for treatment is very, very distressing. Waiting for your next cycle of chemo, waiting for surgery and the pre-surgical anxieties. So if there is a change in treatment modality, if the end of treatment and there is improvement or less improvement or no improvement, discharge from hospital after treatment, how to look after the person at home. So there are various times when it is of increased vulnerability. And then stresses of survivorship, which Dr. Savita will talk about. Even after recovery, there is a fear of recurrence and fear of relapse, and advanced cancer and end of life. So studies have shown between 20 to 40% of patients have significant level of distress. By significant, I would say 6 or more, which is causing a disruption in their life. And very few of them have been identified or referred for psychosocial help. It impacts the impact is that if you don't detect it, it can aggravate and cause more severe problems. It can make a person seek more help and lead to extra visits. They have trouble making decisions. There are so many things to make decision about. What to do in future, unfinished business, how to manage family, how to look after finances. Cancer is a very expensive disease. It not only, and it's a disease which affects everyone in the family. One person might be having a disease, but it affects everyone in the family. So it helps in, it interferes with decision making, and patients are very dissatisfied with their physicians. That's a sad part of it, So they are doing so much, but people feel dissatisfied with that. So management of this requires an extra effort and time from their doctors or nurses who would be doing it. And systematic screening can be done with the help of nurses or volunteers. It can be done before the person is seen, and we should have psychosocial interventions to reduce these. So management, like I said, it should be detected early and screen for it, and then do some interventions. Ultimate goal is that irrespective of managing other psychiatric disorders, we should make sure that distress does not go unrecognized and untreated. The commonest psychiatric disorder, distress is like just one of those things that you need to address and screen, are adjustment disorders. And adjustment disorders are, in most situations, are unrecognized because they think that it is natural for a person to have a reaction. So then they ignore it, then they don't deal with it, but it can interfere with their lives in a big way. So the commonest psychiatric disorders, they are usually short-lasting. It follows a stress of many stages of cancer, which I talked about, right from symptom to diagnosis to treatment, interventions. It can happen with the stress, and the person is preoccupied with stress. I don't know how many of you remember the Jasper's criteria of reactive psychosis. So adjustment disorders have something to that. They're not psychotic level, but it's like that. So there is a stress, there is a preoccupation with stress. If the stress is removed, the distress will be removed, and the person will become free of symptom. And then most of the time the stress is the thinking or feelings are about the stress, and there's a preoccupation with that. And invariably it serves a purpose. So it can be with adjustment disorder, if you remember in the ICD says it can be with emotional disturbance or conduct disturbance. So of course it can be with anxiety, depression, commonly both anxiety and depression, irritability, anger, behavioral problems. It can be with sleep disturbance, obsessional thinking, short-lasting obsessional thinkings, health anxiety, numerous health anxiety. Will this treatment work? Will I get side effect? What will happen with that? How long do I have to take? And when do I need to see a doctor again? So health anxiety. And many times a counseling might help, or a low-dose psychotropics might be helpful. So psychological and emotional reactions can be due to a number of things which I've talked about, including stigma due to cancer and its consequences, fear of death and dying. We as psychiatrists and mental health professionals have a very unique position in society and in healthcare. We are expected to do anything and everything which nobody else can do. When many times I find colleagues who say, people have some stigma against psychiatrists, I don't like to tell. So I said, I feel just the opposite. If anybody asks me, what is your profession? I always tell them I'm more than a doctor. Because I'm not only a doctor, I do, a lot more other things other than what a doctor would do. So the role of mental health professionals and psychiatrists in cancer is everything which an oncologist cannot do. So it starts with, dealing with the patient's fears, with communication, with spirituality, difficult questions, and many of these things we'll talk about, unwanted effects which they can't explain, and stigma. So the one way of adjustment disorders is the reactions, and we all know Kubler-Ross's DABDA, denial, anger, bargaining, depression, and acceptance. I'm not going to talk about it. The commonest coping mechanisms which we see in our country, and this is, for almost 10 years we did a study with the Kidway Memorial in NIMHANS, and we found the commonest reactions were denial, resort to religion, and fate, karma. जो भाग्य में है वो होगा, जो अल्लाह ने किया वो होगा, ये तो होना ही था, and helplessness. In our country we are very used to helplessness everywhere. So they have feeling of helplessness. But these don't help the person a lot. So if you find when they think about these methods of coping, it doesn't resolve. The resolution is quite poor. But this is something which is not much talked about, the styles of adjustment to cancer. When I'm talking about it here is that there are some reactions which are very good. Like a fighting spirit is considered good to have, It not only helps you fight the psychological problems, it helps you fight the disease. So fighting spirit is, and there is research to show that these things are effective. And denial, many times we get, very worked up about denial because we think of denial like in psychotherapy, and we think that it needs to be broken. Denial is a good defense mechanism. It is protecting you. It is protecting you from the distress. You don't have to do anything about it unless the denial is such that it interferes with treatment. If the person says, I don't have disease, why should I go? But our patients are very good. They say, no, doctor, I don't have a disease. You tell them, oncologist tells them, you come for the next cycle, they will come promptly. You go for radiation, they will go promptly. So you come for follow-up, they'll come promptly. So the denial is, a bit of talking about, avoiding talking about it. And then there are others about which we don't know whether it's good or not, like fatalism I talked about, and helplessness and anxious preoccupation like with the health anxiety. Now there is some research on whether a person should know about the disease or not. And there are both types of studies. Some say that if a person is aware about their disease, then they are more likely to get depressed and have depression and then cause additional problems, and it's not good for their disease also. But there are other studies which say that there is actually it doesn't make any difference what type of, whether they are aware about the disease or not. So there is no difference between two groups of patterns or prevalence of psychiatric disorders, whether they are aware or not aware. But there are studies to the contrary to this also. Some say that it can be more, some say that it doesn't make a difference. Most difficult disorder, and which you would be called on in a liaison setting, is depression and cancer. And this is more than adjustment disorder. I'm talking about depressive disorders. So these are there in number of prevalence in different organ system involvement, and we'll talk about that. But the most important thing as mental health professionals and psychiatrists that we have to be aware of it is how the diagnosis of depression is made difficult because of the DSM criteria, or even in ICD, because a lot of symptoms are common. Okay, loss of sleep, loss of appetite, loss of weight are symptoms of depression and are symptoms of cancer. So if one was to count, then most cancer patients will fulfill a lot of criteria already. Or same way, fatigue is in depression, fatigue is in cancer. So loss of sleep, loss of appetite, fatigue, loss of energy, difficulty concentration, psychomotor retardation. So there is a big overlap, so which makes making a diagnosis of depressive disorders very difficult in cancer patients. So a lot of people have used different methods how to diagnose depression. So some are, you can substitute the symptoms. So instead of poor appetite, you substitute it with tearfulness and depressed look, with fatigue, with social withdrawal, less talkativeness, poor sleep with brooding, poor concentration with lack of reactivity. Some people use omitting somatic symptoms. So, out of the list, you just drop these symptoms and count the others. So reduce the number of symptoms required. Or you differentiate whether this symptom is because of depression or cancer. So if a person is feeling fatigue, so it's a judgment you make whether this is because of the disease or it's because of depression. So with some difficulty it is possible, but then it is not very accurate. So this is the number of tools which have been used, and there are many, and the good ones are the Edinburgh Postnatal Depression Scale. It's called Postnatal Depression Scale by John Cox, but it can be used for for diagnosing depression. And Hospital Anxiety Depression Scale is considered very good because HADS is a scale which doesn't have somatic symptoms. It has only cognitive and affective and behavioral features of depression, but not the somatic or the vegetative symptoms of depression. So we have to be very cautious. Sometimes we just use PHQ-9, but we are still not very sure how good it is, or we use other depression scales and they might not be very good. So we used Hospital Anxiety Depression Scale and adapted it in India many years back, and we found it to be reasonably good. So with HADS, when we found, like I said, adjustment disorders were quite common, and then the other disorders. The meta-analysis show in palliative settings as well as in oncology settings, anxiety disorders about 10%, depression about 16%, adjustment disorders a little bit more than that. Depending on the organ system involved, pancreas has a high rate, brain has a big range, head and neck cancers are very common, breast cancers again a big range, gynecological cancers and lung cancers. It's also partly related to demoralization, where a person feels helplessness and incompetent, and there's a lack of motivation in demoralization. It's a concept described, but I have never diagnosed anyone with demoralization. It's there for theoretical interest that we would like to do. So barriers of recognition, like I said early, a lot of people think that if a person has such a disease, they should be depressed. So it's taken as a natural reaction, and patients don't know that whether they should talk about it or not. I should talk about my disease. Why should I talk about something else? And they will take away from the time which have been allocated to them. There's also some biological theories which evidence actually which shows how cytokines and neurobehavioral symptoms in cancer patients have gotten a role in that. The pro-inflammatory cytokines are elevated, patients with anhedonia, and they also have alterations and sensitivity to pain. So, ways of which depression can affect cancer. Why is it so serious? Why do we talk about it so much? Because if a person is depressed, they might not cooperate much for treatment. They might refuse treatment, and motivation is less. They give up. They feel helpless. They avoid health promoting behaviors. They are not very cooperative. Poorly, compliant to medication. There is social withdrawal. So they just isolate themselves. They do not use help and community resources, and they have greater difficulty in tolerating side effects. Risk factors for depression, we all know, so I would probably not talk about this here. Then signs and symptoms, like I showed, they are overlapping. And when I do programs for oncologists, and they say, we don't have the time like a psychiatrist to do a full assessment. So I usually tell them a single item, which is very good and very sensitive for detecting depression, is anhedonia. If you ask, do you feel sad and weepy? A lot of people feel sad and weepy because of a number of reasons. So, do you still enjoy the things you used to enjoy? Do the things which used to give you pleasure still give you pleasure? So I said you can ask one item. If you want to ask one item in 30 seconds, you can ask this. So it will be, otherwise a whole lot of things can be very overlapping. The second important disorder is about anxieties, fears, and phobias in a cancer patient. They have numerous fears. Fear of pain, fear of death, fear of complication, fear of disfigurement, fear of relapse and recurrence. That's, people who have recovered, they feel very distressed about that. Fear of death, fear of dying. Am I dying? Will I die? What will happen to me after? So, you would say that we've never read about this, but you are expected to help them with this, And of course, we have in our armamentarium enough strategies how to deal with this. Needle phobia, especially in children. Same way, features of anxiety. If they want to ask one symptom of anxiety, I suggest to them, which is from the PSC in the present state examination, one sensitive item is, when you relax, are you able to relax? If not, then it's an indication that you've got anxiety. So if you ask, do you worry a lot? Of course, we worry a lot. We worry a lot about 100 things. So how do we differentiate that? And again, autonomic symptoms can be there because of a lot of things. So if they want to ask a single symptom, that might be there. So physical, psychological. Now this is a specific disorder which we do not see in psychiatric practice otherwise, is anticipatory nausea and vomiting. So it is a conditioned response related to chemotherapy. So because chemotherapy is so toxic, and it is so toxic that the whole field of quality of life emerged from that. People started asking, is it really worth it to take such medication? So it's an issue about life and suffering in life. Would you like to have a short life without suffering, or would you like to have a long life but with suffering? Everyone has different opinion about that. So anticipatory nausea and vomiting. So the moment the person has to come for their next cycle, even from home itself, they start feeling edgy, anxious, avoidance. They would, get nausea. They would, get a lot of distress. Talking about how it's like it's partly like PTSD type of thing. Even if they see it in a movie, and then that triggers off. The moment they come closer to the hospital, their symptoms increase. The smell of the hospital, the disinfectants, detergents, hospital smell, which we all know. We get used to it so commonly. Patients don't. That increases their anxiety. So two types of interventions are helpful. Since it's a conditioned response, behavior therapy is very good. You can do systematic desensitization or give low dose medications just before the visit to the hospital. and preventing severe nausea in the first chemo session itself, it can be a key to stopping it from developing. Now, we talked about somatic symptoms and depression. In our practice, we see a lot of somatizers. We see a lot of patients with headache, backache, multiple aches and pains, somatoform disorders, somatoform pain disorders, somatization disorders. We see them, isn't it? And when we see them, the underlying cause is either emotional factors, depression, anxiety, psychogenicity, a lot of things. Now, all these things are there in cancer patients also. Now, it's a very awkward situation because here we have a person with a physical disease, having physical symptoms. Now, are these physical symptoms because of the disease or because of somatoform? Is something. So, this was the study which I did when I was in Christie's to look at somatization in cancer patients, and found that there can be what we call as abnormal illness behaviors, unexplained. You'll find the oncologists say that, I don't expect this person to get fatigue. Why is this person getting fatigue? I don't expect this person to get pain. Why is this person getting pain? The person is disease-free. There is no evidence of disease. Why is this person still having symptoms? So tiredness, why is this person having abnormal sensations? So there are many studies which have done in survivors, and they found that they had physical symptoms which were indicative of, which are medically unexplained symptoms in a person with a medical disease. Now that is, it can be very tricky. We have to be very, very cautious how to diagnose them. So in my study, I found a lot of symptoms, sensory symptoms, reduced energy, fatigue, and a lot of patients had either depression, anxiety, or somatoform disorders. Such people have more somatic preoccupation, somatic concern, and many times their symptoms might be interrelated. Pain might cause fatigue, fatigue might lead to pain and inactivity. So also, if you recall, there is something called as alexithymia. Alexithymia is more in somatizers. Cancer can cause secondary alexithymia, because of the nature of the disease itself. So alexithymia causes somatization. So etiology, like I've talked about, it can be because of both organic factors, medical factors, psychological factors, alexithymia, somatic preoccupation, and a manifestation of illness behavior. Implications are, like I just mentioned, how do we treat them? If a physician misinterprets this, they will make their physical treatment even more aggressive. That is not what is required. So it can result in poor outcome, recurrence, and luckily there's a very good response to antidepressants and cognitive behavior therapy. Just a few words about some of the other disorders. Sleep and wakefulness disorders in cancer are also very common. Insomnia is there, which might be related to physical symptoms, psychological symptoms, or it might be difficult dream state. Sometimes we find patients, who have got, I don't even know how to call it. They don't want to sleep because they think they might never wake up. So that's a fear of sleeping, and that's a sleep disorder. And they would refuse to, take any hypnotics, So for a number of reasons, it's very difficult. So they have different types of sleep disorders. Post-traumatic stress disorder, it's not very commonly talked about, but it happens in a number of stages. Process of diagnosing, like I mentioned about a case, the way a diagnosis is given, patients do not remember very often what you have told, but they always remember how you have told, what you were doing, what was your reaction, how you talked to them, whether you listened to them or not. So the process of diagnosing, communication, collusion, Dr. Shubha was mentioning about keeping the disease secret. It has its own impact. Collusion can affect a lot of things. One of the things we need to do as mental health professionals and psychiatrists is teach them how to break collusion, so that the communication is improved within the family and they can all help each other instead of having a conspiracy of silence and not talking to each other, and at a time when they should be talking, it's very unfortunate. Mastectomy, surgeries, chemotherapy, anything can have a PTSD type of thing. Body image problems and sexual dysfunctions, whether a self how do they feel themselves, as a man or a woman, after having a surgery or after having a chemo, after having, lost all their hair. So the asymmetry, the scars, the ostomies, and all of these cause a lot of body image problems. Loss of libido, either because of the disease or because of the treatment or because of depression or because of anything else, so loss of intimacy. I had one person who, I cannot forget, it was, in their 60s, or early 60s. And this person, gentleman, had a multiple myeloma which was treated and he had recovered out of it. But he had some sort of, I don't know what to call. He wouldn't let his wife come and touch him, hug him. She said, I just want to hug him. I don't want to do anything else, but I just want to hold his hand. He said, he just had an aversion to that. These are very difficult situations. The disease is gone, but this is affecting their quality of life. When they want to be together, they can't be together. When they want to be intimate, they can't be intimate. So, very, very, confusing and very complex, which we need to discuss about. Of course, sexual dysfunction and psychosexual dysfunction, these are not only in organ systems which involve reproduction. Any cancer can cause sexual dysfunction. And these can be loss of desire, pain during intercourse, change in genital sensations. We had one lady who said she just doesn't feel anything after treatment. And, gynecologists examined, they said, no, sense and touch and everything is fine, and, but they don't feel. There is another sensation which is there, which is numbness which is there. Decreased ability to reach orgasm, delayed orgasm. 50% of women treated for breast and gynecological cancers have long-term sexual dysfunction. And many times they do not resolve after a long time. Why do we need to talk about it? Because this affects quality of life. It's not only living, it's how you live and, how do you improve on that. Alcohol, substance use are more we talk about as an etiological factor, but I would just mention about pseudo-addiction. This is when a person in palliative care is on opiates and their patient is asking for more opiates, and many times doctors suspect that this person has got addiction. And that's why they're asking. So we need to differentiate. That's why we call it, the term has been coined, pseudo-addiction. They are asking for more morphine because of inadequate control of pain. So it's, sometimes you get referral, why don't you assess? I think this person has got addiction. So you have to be very, very sensitive examination and assessment that whether it is because of unrelieved pain or a breakthrough pain, or is it because of a person wants to get a high or a kick, or various factors which can, which we relate with addictions. In organic mental disorders, we are very familiar with these, disorientation, confusion. These can happen in phases. It can happen at any time. So, principles of psychological management, I think Dr. Savita will talk more about survivors, but I'll just give a brief overview. Sensitive breaking of bad news, how we do it. Somehow, I don't doubt it, most physicians, forget oncologists, all physicians think that we have good skills in breaking bad news, which I know that we have good skills in breaking bad news, and we should also teach people how to do it. Breaking bad news is a big thing, providing information. How to make a person express their emotions. This is something which we are skilled at. We should help people be able to do that. How to, encouraging confiding tie. This is something very, interesting, which I noted in, when we, if a person has a good confiding tie, it's a good prognostic indicator, not only for the disease, but also for the psychological reactions, and it's got nothing to do with anything, even in life. If you have a good confiding tie with a person, you're going to have a better life than those who don't have one. So setting realistic goals, So there should be appropriate package of medical, psychological, spiritual care. So this is just a summary. It's a sixth vital sign. We need to look at various things. Need to train trainers and teachers. That is a bigger job that we have, is to train people. Train the oncologists, train the nurses, train other oncology staff. So this is just psychiatric oncology. This was my DLN Murti Rao oration. So I did my work on that. These are the two books which Dr. Shobha mentioned. And my son is a stand-up comedian, and Jagdish Chaturvedi is an ENT. I complained to him that I don't have much views and likes. He says, wherever you go, you ask them. So I would request you to subscribe to my channel and like my videos. Thank you very much.
Thank you so much, sir, for that very comprehensive lecture on all the psychiatric aspects, from psychological distress to depression. And I feel the key points were the single question that can be asked to determine depression, to determine anxiety, and how we can be partners in care. I think we have to be in close liaison with the oncologist.
Absolutely.
Otherwise, we may presume that just because a referral has come to us, they have ruled out that it is because of pain or organicity. I mean, we need to check back with them, I think, and how difficult it is to differentiate psychiatric symptoms from consequences of the disease itself, and what role they can play. House is open for question answer session. Clarify any further doubts, comments.
Yes, sir. Ravi Abhyankar. Ravi, don't ask me a question. You only tell.
Yeah. I got very long association with Dr. S.K. Chaturvedi. In olden times, when we used to contest elections at IPS level, it was like style and vogue to get proposed and seconded by people from different zones. Like if I am from West Zone, I get someone from Central Zone. Or so when I contested for one election, I had asked Dr. Chaturvedi from South Zone to propose the second one. Anyway, my question is, what is the role of pre-sickness personality in cancer survivorship? Because in society we see that people who have got ability to tolerate stress, uncertainty, those who have resilience, they are able to survive cancer better. Like classical triad of antisocial personality, lovelessness, fearlessness, guiltlessness. Such people who otherwise we call nasty people, they are able to survive cancer better. And we see, politicians, they are able to survive cancer much better. So I would feel that paranoid and antisocial personalities survive cancer better. So are there any studies about this?
Well, it's very interesting that you ask it. I actually didn't want to go to that field. In 60s and 70s, there were a lot of studies to look at cancer-prone personalities. The type C, they used to call it. And the features were similar to the type A for the cardiac disorders. And also, people having, like you said, if they are anxiety-prone, unable to, poorly resilient, they are the ones who are likely to have that. But when the time came for more evidence-based, and people stop talking about cancer-prone personality. So we are not very sure. Maybe there's a time again now to re-look at the coping and how do they, what are the prognostic value of some of the personalities. Now, ICD-11 has done away with the types of personalities. So such research is a little more difficult, but it's still, it's a very important point. In consultation liaison psychiatry, people question this, that should we start on antidepressant, low-dose antidepressant before a person develops depression? Will it help? It's not really about depression. It is about diabetes and any other medical disorder where there is a high rate of depression. So and there are people who believe that one should prevent it. There are people who say no, let's wait and watch and let it develop. A lot of people don't develop. So these are some questions which are still unanswered, I hope. Yeah, Dr. Davi.
Described everything in great detail. I have been also dealing with I am one of the trustee in Cancer Charity Trust, and also attached to a private cancer hospital where a lot of references are sent to me. Of course, the dilemma is some of the patients ask that ultimately if we are going to die, if the advanced cancer especially, not the initial one, and sometimes openly ask us whether it is worth going for treatment. Doctor, why you prolong my life and make me spend so much money, which I would like to keep it for my family members? And these questions are very tricky. Some of them prefer to die earlier than to suffer the treatment, the consequences, and other things. While cancer specialists make us motivate them to take the treatment. And here the dilemma is such. Of course, Joyita is going to discuss about this therapy part, because she must be facing these problems more often than me. But, taking little bit of philosophy in this, that even these questions directly hit us, that whether, what to advise in these conditions. We try to, at least I have tried to tell them, see, our job is to reduce suffering and promote quality life. If we can do something in this field, the reduction in suffering, I have witnessed a very close friend of mine on whose name I had started a rehabilitation center. This gentleman, he was an industrialist with 7 chemical factory and philanthropist and a very wise person who used to give lot of donation and do the work. And he was afraid of, he used to tell ki I am afraid of 2 things in life. One is that I should not lose my speech, because he was a good orator, that till end I should continue speaking. And the second thing, I should not get paralyzed. And this man suddenly got a laryngeal cancer, and he went abroad. He was affording. His son-in-law was a cancer specialist. He removed the larynx. He came with a instrument like this in Bombay, and he told me, get me the list of people who had done laryngectomy. I would like to give a donation of similar instrument to everybody. And within 2 months, he had a recurrence. And this local cancer went into the spinal cord, and he got quadriplegia. He never wanted to lose his voice. He never wanted to get paralyzed. And this was something which cannot be treated. And then he got an obstruction, venous obstruction, and his face got edematous, and his eyes were buried. He cannot see, he cannot write, he cannot speak. And this, which he never wanted in life, and it happened in the reality. And he told me, it is painkiller injections you are giving. Why don't you give a high dose and finish me off? This is something which in a close friend of mine I had witnessed. And at this time you yourself think, what to do about these people? whether the mercy killing is advisable. Of course, I said my job is not to kill anybody, to make you comfortable. I can relieve the pain, but I cannot finish you like this. So, while treating cancer patients, many of us get conflicts in our own mind, philosophically, spiritually, what to do about this. I think Joyita will tell us more about this. Thank you.
Yes. Then Dr. Vahia Dr. Vahia has put his hand up for a long time. After this.
Sir, contrary to what Dr. Dave was talking about, a lot of times I get references for somebody who's like 85, 87, and when I go to see the patient is in a delirious state. The relatives are unwilling to give up. I call the doctor, the treating cancer specialist, and they say, we have tried to tell the prognosis and not to go ahead with the treatment, but family is not giving up. Sometimes the patient themselves are in such denial that they are not giving up. So I don't know how to proceed with that, because there is no follow-up, there is no systemic study that I can do at my level. So I have no idea. If it's a relative, it is still, there is an attempt to talk to them, sit with the cancer specialist and try to orient them. It doesn't always work, but something that can be done. But when it's a patient, it's a very difficult thing to manage, because I don't know what to do ethically, actually.
Yeah, no, it's a very challenging situation. And just pass it on. Yeah, he's got him.
Nice seeing you after maybe 3 decades. 3 decades, yeah. I have not met him. I don't think we have met for the last 3 decades. Before that, we used to meet often enough.
Yes.
One point that you raised about antidepressants, small doses without signs of depression. There's a study by Lou Judd when he was with the NIH of those were the days when only 10 milligram fluoxetine was available here. He has data to say 5 milligrams of fluoxetine with just one symptom of depression and not a florid depressive syndrome works well. This one. Second point related to what Dr. Kulkarni asked, denial. Denial to accept the diagnosis, denial to accept the prognosis, denial to accept that the health is deteriorating, and sometimes in fact presenting with hypomanic or manic features. On a lighter note, oncologists gave a packet of medicines to a patient of cancer and said, I'm giving you a medicine which you'll have to take 1 tablet every week. He opened and said, there are only 3 tablets. He said, exactly. So that's second point. And the third is fear of contamination.
Yeah.
And this comes from Google medical graduation. People read Google. Google says it is genetically transmitted. They forget the word genetic. They say it's transmitted. And that's one of the reasons why your patient would not allow the wife to hug him, because afraid of contamination.
Yeah, absolutely right. When you explore, they give a number of reasons. So thank you very much, sir. See, death wish is a common thing in cancer patients. And we, again, like anything, it can be primary or secondary. Most of the time it is secondary. It's because of pain, because of suffering, because of being a burden, because of troubling other people. A lot of these things can be minimized. But if it is coming from inside, if it is primary, it's really a big challenge. So at present, there is a movement in the palliative care fields about having advanced directives, which is very helpful. If a person can give that, it helps in decision making. But otherwise, our job as mental health professionals is just to help in decision making. We don't decide for anyone, and we should not decide for anyone. It's not only unethical, you will end up with moral distress because of that. Anyway, thank you very much for all your keen interest. Thank you.